An occupational therapist begins working with the client by gathering pertinent information such as family history, medical history, concerns, and the client's concerns through interview and observation. OTs are responsible for evaluation of a client, choosing assessments, and initiating therapy. The OT has primary responsibility in intervention planning, the outcomes of intervention, and establishing discontinuation. OTs are responsible for all aspects in delivering occupational therapy service and are held accountable for effectiveness and safety of that given service in any setting in which they work. An OTA may not independently evaluate or initiate therapy, but may administer structured tests in which they are competent. They may also report observations according to the Kentucky Board of Licensure for Occupational Therapy 2012. The OTA may contribute only with specific tasks as indicated by OT. OTAs may assist with documentation, but the supervising OT must sign the documents within 14 days for official placement in client's records. Aides serve more as a preparatory assistant to set up a patient's room or organize resources for therapeutic activities. They do not provide the same level of skilled services as OT, and that they typically will not make as many contributions to treatment planning and documentation. So there are some differences in the roles between settings, such as the type of population they're going to work with, typical diagnoses, and the focus of interventions and the strategies used. So I have some outlined on the PowerPoint. So ADLs are usually addressed in early intervention, school-based, inpatient, and skilled nursing facility. Sleep, early intervention, inpatient, and skilled nursing facility. Play can be addressed in any setting, but is highlighted within early intervention and outpatient pediatrics because it's a child's main occupation. Social participation, any setting. Psychosocial issues can be addressed in any of these settings, but usually isn't the main reason for occupational therapy referral. Leisure, school, outpatient pediatrics, skilled nursing facility, and outpatient adults. Functional mobility, inpatient, skilled nursing facility, and outpatient adults. IADLs, more so adults, would mostly be used in inpatient and outpatient adults. Environmental modifications can happen in any setting, such as school, working on environment modifications if being discharged from a skilled nursing facility or inpatient, community-based psychiatry to address sensory issues. Supported employment is oftentimes through community-based psychiatry, and coping strategies are often used in any setting where a person is going through a life-changing event, often could be seen in inpatient, skilled nursing facility, or community-based psychiatry. This could also be used in pediatric setting if a child has experienced something life-changing or even just having some challenges. So a case example could be a child with sensory issues. And so they could be seen in early intervention for feeding problems to support self-feeding. And then they can move to outpatient to address play and social participation because the child avoids the playground. And then school could be because of visual perceptual skills and attention. So we want to work on literacy activities and other skills to promote participation in the classroom.